Hello, everyone. Welcome to ECHO. I know we just gathered last week on the 28th, so thank you for coming back so soon. We'll give it a minute or so for people to come on, and then you'll see any disclosures we have or that we have CME, and then we'll just run through a brief housekeeping and we'll get started. And we're very fortunate to have Dr. Carrie Rubenstein here to talk with us today. Thank you, Carrie.
It's my pleasure, Nancy.
So maybe I think if you would start sharing, and I'll jump right in. Hi, Ursula. Thank you. Great. So as I said, welcome back to Alaska Project ECHO Dementia. This is our 5th session, and we're going to hear Dr. Rubenstein talk about delirium prevention in dementia and really geared towards primary care teams and implementing this age-friendly 5M framework, which we've been talking about and which is, I think, familiar to many of you, to really prevent delirium in folks who are living with cognitive challenges and dementia. Next slide, please. Okay, so we know that because we have this very precious hour, we don't go through our introductions, but here's our hub team. Next slide, please. And as we saw earlier in the scroll, we have CME credit for your participation. And in order to receive that credit, please do fill out the evaluations following the session. And you have a month after to complete them, but ideally, if you have time, complete them after the session. Thank you. So it's top of mind. Here are our disclosures. We take this very, very, very seriously, and we have mitigated any of these concerns. So next slide, please. Okay, so we're not going to make the intros as we said. Next slide, please. And we really invite you all to show yourself if you can, and also say your name and unmute yourself, say your name and ask your question or share your comment. We can also be monitoring the chat if you prefer for us to read them, no worries. We just are really, really interested to hear your thoughts, answer any questions, to really engage in a, in the all teach, all learn kind of space of this process together. So we can share with one another and learn from each other. Next session, please. So
I can take it from here.
Yeah, would you? So thank you again, Dr. Carrie Rubenstein. I guess you can share who you are.
Yeah, I am just really delighted to be here. Thanks to Amber and Nancy and Chris and team. And I'm really excited that this Project ECHO Dementia is reaching our colleagues in Alaska. And so if somebody else could help monitor the chat, and feel free to just unmute and speak up if you need to. I'm a family physician and a geriatrician. I take both of those roles seriously as part of who I am. And in that capacity, I practice patient care at Swedish, where I direct the Geriatric Medicine Fellowship, which is a 1-year fellowship after family medicine or internal medicine residency. And I'll mention for any of the family doctors or internists in the audience, I not infrequently get folks years out of their residency training to come and do fellowship. So if you're interested in that, please do let me know. And then I also serve as a core faculty in our family medicine residency. And so I'm always thinking about how to best teach best care for older people to a wide variety of learners. And I also have the great privilege to practice in multiple different settings across our care continuum, in the clinic where I do primary care and consultations, in the hospital, in nursing homes, in adult family homes, in people's private homes. We've started a home-based primary care program out of our fellowship. And so it's pretty cool a job that I have, and I feel very grateful. And I have no doubt that the work I am doing and that I am here to speak with you today because I am also the daughter of a dementia care partner, actually dementia care partners. My mom and dad cared for my grandma Ann from actually the time before I was born, but through my childhood when I got to witness living with a person with dementia, and also sort of all the beauty and joy that can come of it, even despite the challenges. And so with that, I will go on. My goals today, my objectives are to really review the age-friendly health systems framework, and I'll just give a little bit of my spin on it since I know you've heard about it already. I'm going to also describe delirium risk from the primary care perspective, and so I'll emphasize this a little more because so much of the research and so much of the talks that you've probably heard about delirium are really from the hospital perspective. And so really trying to prevent delirium, to prevent people from getting in the hospital in the first place is really so much of the good work that we can do together. And then I'm going to use this age-friendly 5Ms framework to think about how we can actively prevent delirium in our day-to-day practice when we take care of people living with dementia. And then I'll mention, I think you guys have already heard a little bit about it, but I'll also just share with you or introduce you to the patient priorities care tool and how it can help you focus on some of your most complex patients. Because we know that people living with dementia often are not just living with dementia, but living with multiple chronic conditions as well. So why did the IHI and the John A. Hartford Foundation, the American Hospital Association, the Catholic Hospital Association, why did they come together in 2016 to create this movement we like to call the age-friendly health systems? Well, the problem they were trying to solve was that we know from years and decades of research that there are evidence-based programs to improve the care for older people, but they are only reaching these like sort of niche groups. And so one of those programs you've probably heard about is the PACE program for all-inclusive care of elders. And this is an amazing program that it really practices age-friendly care and has for decades, but only to this small group of people who are lucky enough to be part of a PACE program. And there are other programs such that are evidence-based care for older people, but really the idea of the age-friendly health systems was to deconstruct those programs, identify the things that really matter in terms of outcomes for older people, and really focus our teaching and our efforts on assessing and acting on these essential elements that matter, which are the 4Ms and the 5Ms that Providence has created to improve the care for older people in a consistent way across care settings. And so we think and we believe that age-friendly health systems really improves dementia care by focusing first and foremost on what matters. Not only what matters to the individual, which is the most important thing, but in dementia care, we think about the dyad. We think about the person living with dementia and their care partner, also known as caregiver, together. And we'll be talking about that a lot today. And then we think that if you keep this checklist, and if it's in your mind, that's great. If it's in a template, that's even better. We'll talk a little bit about EHR and implementing age-friendly health systems into an EHR more consistently. But if you use these 5Ms to guide your care, you're going to be giving more consistent and more comprehensive care. And what I'm going to talk about today primarily is how do we assess and act on the 5Ms to play a role as primary care teams in delirium prevention. And so none of this is surprising to you all. Like, why do we care about delirium? Because delirium is really common, especially common in people living with dementia. When our folks with dementia get to the hospital, it's often not just more costly, but more impactful on their dementia itself. We see it progressing more rapidly, on a higher chance of living in an outside the home, where we know people want to stay at home often as long as possible, and mortality. So delirium is so is so key and so critical and so important for us to talk about, because if we can prevent it, then we are it can make huge impact. And so I want to start by telling you about Pat. Pat is a real patient of one of my fellows, Rachel, who is not here today, but she's a geriatric medicine fellow. And Pat, this is not Pat's picture, and this is not Pat's cat. But really, if you go all the way to the bottom to start with, what really matters to Pat, really matters to her, is that she gets to live at home and she gets to be with Leah. And I think we've heard the story more than once, right? But she is an 80-year-old person living at home with middle stage mixed type dementia. She had a recent stroke for which we cared for her in the hospital. And around the time of that stroke, she had this unfortunate experience with urinary retention. We had to send her home with a Foley catheter, but we actually got her home, and that was really what she wanted. We wanted her to go to a post-acute rehab setting, and she just said, nope, I don't want to do that. And we got her friend, who's an unpaid care partner, to sort of help us set some kind of supervision for Pat at home. We got some home health OTPT, some home health nursing, and she expressed some hopelessness and some depression in the hospital. And so we started her on an SSRI for that as well. She has significant hearing loss. We used a pocket talker in the hospital. She does not have well functioning hearing aids. She hates her Foley catheter. And she's actually she was part of our home-based care program, where the fellow that was caring for her was able to visit her several times after hospitalization at home, which was really great. And she videoed me in, and I got to meet Leah, which was really cool, after taking care of her in the hospital and hearing about this cat. And so in the chat right now, I would love for you to look at this history and tell me, what strikes you, like what are Pat's delirium risk factors? And if someone can just read out loud once people start typing.
A urinary tract infection.
So infection, thank you.
Her cat dying.
Oh, sorry, her cat didn't die. Did I say her cat died?
No. That's a concern about.
Oh,
yeah.
Okay,
Hearing loss. I'm just
hearing
reading
loss.
loud.
Yep.
Hearing loss doesn't help with dementia.
Hearing loss and is also a delirium risk factor, right? Sensory deficits. What else?
Hospitalization.
Even for people who go home, they can go home with delirium, right? Leaving the hospital does not, unfortunately, we wish it did, cure or prevent delirium.
New medication.
Possibly. So she's, yeah. And something very specific, and we'll get to this, but her SSRI has a risk of hyponatremia. Hyponatremia and electrolyte disturbances can put people at risk for delirium. What else?
And immobility related to the catheter.
Absolutely. And the catheter itself, and the fact that she hates the catheter. Yeah.
And then the caregiver likely does not have dementia training. These are great answers. Really so important.
Really, really thoughtful. Okay. And so this is, she doesn't have a 20-page problem list. She has a relatively short problem list, but what else here? Is there anything else? We've hit most of the things, by the way. And nobody said it, but I know you're all thinking that, like, her dementia, right, is what probably her biggest delirium risk. But what else? Anything else?
Pain from the catheter.
Right? And then constipation. And this is going to come up a bit as we go further, but not only does the constipation put her at risk for urinary retention, right, but the constipation itself puts her at risk for delirium. And there have been many, many times that I've seen it, and many of you have probably seen folks that actually present with delirium and they have a big fecal impaction. And so we need to be really serious about preventing these things and treating these things when they come. You can see her medication list. thyroid abnormalities can lead to delirium risk. And it turns out that when Pat came into the hospital for her stroke, she had a very elevated TSH, which made us think that she wasn't adhering to her medicines. And certainly that's a risk for her as well. She doesn't have too many of the meds we'll be talking about later on because she is cared for by one of my excellent colleagues. But we'll talk about how to look at a medication list and how to identify those high risk meds for delirium. And so this is just a slide, like the nuts and bolts of like what puts people at risk for delirium. And we've talked about a lot of them and you identified them in our patient. But new medicines, like somebody astutely pointed out, drugs and alcohol, I didn't mention, but Pat does not drink any alcohol and she does not use any drugs. And she does not have any use disorders. High risk drugs, we'll get back to this a little later on, but like this is such a key point in what we do in the primary care setting. We talked a little bit about electrolyte disturbances. We'll talk about nutrition and hydration a little later on as part of our 5 M's. Lack of drugs. If you can see this is like a medium quality acronym, right? Like delirium. You can see that down the left. We're on lack of drugs, which is okay. So withdrawal of certain medications, or if Pat had pain that was poorly managed, or if people have pain that are poorly managed, the lack of treating that pain can lead to delirium. We always think about the opioids leading to delirium, right? But pain can also lead to delirium. Reduced sensory input, we talked a lot about this, vision and hearing, things that happen intracranially in the brain, like infection, hemorrhage, stroke, and tumor. So the stroke she had prior to her discharge puts her at risk for delirium as well. We talked about the urinary and fecal issues. And then the last M is for myocardial, so cardiopulmonary, like exacerbations of chronic diseases are all also delirium risks. And my goodness, this is like, she has so many of these. This is my highlight of Pat. And we'll get back to Pat at the end, but really just sort of using her real story to think about to identify the risk factors for delirium and really actively manage them in the primary care setting is really my point with telling you about Pat. And then, we think that dementia is one of the, if not the strongest predisposing risk factor for delirium, right? You have this vulnerable brain, whether it's from the plaques and tangles of Alzheimer's disease or whether it's from previous stroke or other causes. If you add that vulnerable brain to stressors, and the stressors, many of which we've talked about already here, this leads to a very high risk for delirium. But the reason I put this plug for early detection is if we don't know somebody actually has dementia, then is really hard to, first of all, actively manage the things that can lead to delirium. But also when somebody shows up in delirium, we need to know what their baseline is, right? Are they delirious, or actually are they just presenting with a dementia that nobody diagnosed? And this is why it's super key, of the many reasons you've already learned about, to have early detection of dementia. Okay, and so this is just like a sort of take-home summary of what we know about hospital delirium and how do we address and prevent hospital delirium, okay? Avoid high-risk meds, and we're gonna talk about these in a little bit later on. We're gonna manage fluids, and especially in the hospital, we need to avoid dehydration. We also need to avoid overhydrating and exacerbating people's heart failure, especially as they're older and more frail. We need to get people moving. Somebody already mentioned that earlier in the Zoom chat. We need to minimize the sleep disturbances that are part and parcel to what happens in the hospital. Minimize the perceptual and sensory deficits. Think about sort of what's happening in the person's environment, because it's all quite delirogenic, right? We know that. I mentioned here, without going into a lot of detail today, there are really great evidence-based bundles that we can use in the hospital and programs like the HELP program to help minimize the risks of delirium, and including using our pharmacist specialists. I hope Zoom chat in if you are a pharmacist joining us today, because I really hope so, because key partner in delirium prevention, especially in people living with dementia. And so really what I want to do in the next section here is think about then how do we apply this to our ambulatory practice, and how do we use this 5M's age-friendly lens to actively manage our older adults living with dementia to try to prevent delirium in the first place, okay? And so the first thing, first and foremost, always and forever, is leading with what matters, okay? And, you know, I would love to hear your favorite questions that you ask people. And I want to make one point here, which is when we think about what matters to folks, sometimes you go immediately to code status or advanced directives. And what I want us to think more holistically about is like, what matters? Like for Pat, what matters is like being at home and being near Leah. And these are just some questions that I use in my practice to try to get at what matters to folks, because this is really key when we're creating our care plans and when we're thinking about what interventions we may or may not do. And so if you have another favorite question that you like to ask, please put it in the Zoom chat. We are going to talk a little bit about advanced care planning and serious illness communication, because if we work really hard to understand our patients, if we learn about what matters to them, and if we tailor their care plan to what matters, and we limit the excess care that sometimes comes part and parcel with either our care or our specialist colleagues' care, and from the primary care perspective, if we can limit that, then sometimes we can actually prevent delirium by keeping the care more simple and keeping it focused more on what matters to folks. We're going to talk a little bit about advanced care planning and serious illness communication in the next slide. But the other thing that I'm going to talk about a little later on in terms of what matters is, remember, we're thinking about what matters from an individual, the person living with dementia, but also from a dyad perspective, their care partner. And one of the things I think we can do as primary care teams is we can train our care partners to identify delirium. And one of the ways we do this is that we teach better about what to expect with dementia. We talk about prognosis and progression and what's normal, so that our care partners can really identify when it's not normal. And they will often be the people who will identify delirium early, and if we train them to do that. And so again, as we're getting to sort of tailor our care plan around what matters, we need to understand that from a patient perspective. And I'm not going to go into this in detail, but I encourage you to listen to this Jerry Powell podcast. There's sort of this interesting debate / discussion in the geriatrics community about the old processes that came with advanced care planning, where you talk to somebody about their hospital goals or their code status, and you check to box off on an advanced directive. And we're really sort of moving towards this concept that it's a process. Serious illness communication and advanced care planning are both important, and they have this overlap, and that we in primary care should have a process by which we approach this. And this is what they talked about, these 4 steps. And they're not surprising to you, but I think if you really get them in your head, I think addressing serious illness communication using these 4 steps will be very helpful in terms of guiding people and understanding what matters to them. I'll also mention that this is another place where the patient priorities care tool and program comes into light, and I'll mention that at the end. But really, it's like getting to know the people that we care for and understanding what's important to them.
Carrie?
Absolutely.
Can I just briefly, thank you. I'm just going to, Ursula, if you want to unmute yourself and share, I think it's a lovely comment.
Oh, sure. Yeah. Carrie, I love the questions you had to get at what matters. I think that that really helps to have those sort of triggers, and those remind me in palliative care and the serious illness conversation that what brings you joy is something I use in pediatrics to geriatrics, and it's a really good first question, or a great question that also helps build rapport and understanding. And then sometimes I go in with, if I want to open up this to get at what matters to them as people, is the patient dignity question, which is, what do we need to know about you as a person to give you the best care possible? Sometimes I find that a little too open-ended, that the like what brings you joy, and as you're getting at the benefits and burdens around how they look at healthcare, is sometimes more relevant for care planning. But that that always leads to something interesting. I love asking that question, especially when I'm stuck.
Yep.
Thanks.
Thank you so much for sharing. I'll give you one more, which I've just started using in my practice. I hadn't used it before, but at the end of a visit, it's been great seeing you, and I'm so glad that you came in today. Is there anything that you were hoping we talked about that we didn't, right? And a lot of times that's going to get at what really matters, right? And people will often leave the visit and they'd be like, wow, like she didn't even ask me about this thing. This thing was really important. And so another little consideration, I think. And I will also say that's really hard in primary care where you have two people waiting for you. And if you ask that question, you may have to sit and listen to the answer. Okay, so the next step, and maybe one of the most important things we can do as primary care teams is to assess and act on medications that can cause delirium. And that in order to sort of like head it off at the start, if we need a medication, like a new medication, for instance, we want to choose one that doesn't interfere or interferes least with the other M's, right? Mobility, mentation, and what matters. And so, this is, again, no surprise to anyone, but these are the classes and groups of high-risk medications that are most likely to lead to delirium. And what's really important to think about is it's not just one person, let's say they're 80 years old and they're living with dementia, and one of these meds over a short period of time to treat something like a hip fracture, right? You're going to need some opioids most likely, but it's multiple medications from these different classes at certain doses over certain periods of time that really compound the delirium risk. And so you really want to be basically running that list, looking for these high risk meds and looking for opportunities. Anticholinergics are, classic, right? We know not only do they put people at risk for dementia in the first place, but they also put people at risk for delirium. And I just have down here the anticholinergic burden calculator. I don't know if you guys have seen it, but I'm waiting for something like this to come in Epic, where I could click on a medication list and understand the anticholinergic burden of the medications that I prescribe. But you want to be actively managing this medication list, and you want to be identifying these high-risk medications. And then you want to be thinking about, are any of these medications, could we de-escalate a dose, or can we deprescribe? And deprescribing is, I feel like, is sort of like a superpower if you have it. Like, it's a really important thing to do. Many of our patients want to be on less medications, and that there are some really great tools to help us deprescribe. And this is one that I really encourage you to check out, deprescribing.org. And they have not only great patient-facing educational materials, but they also have really specific deprescribing algorithms for a certain number of classes of medications, and a lot of the ones we think about. So benzos, Z drugs, PPIs, dementia medications, and I think they're really helpful and engaging. And so as preparing for this talk, I put a little Twitter question out to my community there. And this is just a little plug. I'm not a huge social media person, but I've really found Twitter to be professionally enriching in a lot of ways. And so I said, hey, I'm talking to a Project Echo group about this topic of preventing delirium and dementia. And so I was going to share with you a few of the comments I got back. So this is a Stanford geriatrician that said, for PCPs, I think prevention is really via like avoiding potentially inappropriate medications. So like what we're talking about. And the Beers criteria, if you're not aware, is another tool that we use for this. And then he just highlighted how often he sees constipation leading to delirium. And so keeping that in mind. So mentation. So obviously, Project Echo Dementia is all about mentation, but the dementia piece and the delirium piece is actually not the only thing we think of when we think about mentation from a 5M standpoint. And so we've already talked about how, and I'll talk about it again on the next slide, I think, early detection of dementia and how important that is in prevention and appropriate assessment of delirium. Well, the other thing that's really important, especially as we go into a very prolonged pandemic state, is depression, right? We need to screen for and treat depression. And then we need to address social isolation and loneliness. And, you know, if there are silver linings that have come from the pandemic, there have been some really creative ways that people have addressed social isolation and loneliness in the time of COVID-19. But there's no question that this is a major issue, a risk factor. We know that actually social isolation and loneliness are risk factors for dementia, and so is depression. And so we really want to be able to address these things. And then, you know, the other thing I think about in terms of mentation is I think about the care partner well-being. So, like I said, if we do it right, we have a team of people that are supporting our patient and their care partner from diagnosis and throughout the dementia care journey. And this is one of the things where I love the Dementia Road Map, which I have always within like arm's reach, which is an amazing tool that is developed by the Dementia Action Collaborative, of which many of your hub members are active members, and has some Washington State specific tools, but it's also really amazing in terms of sharing with folks the diagnosis of dementia, understanding the progression of what does mid-stage dementia look like, and making sure that the care partners have the support they need in multiple ways. And we're not going to go into that because I know that's a topic for another Project Echo. But knowing your tools and using them to address the care partner's well-being is a key step in not just dementia care, but also in prevention of delirium.
Carrie, just a moment. I'm just going to add from the chat, just to echo that, because I think it is really resonant with what you said around kind of the dyad and the care partner well-being. So, and in the service of time, I'll just read Gay Wellman when asking about, you know, what should we know about this person or what brings joy, asked, you know, if the person really can't express that, turning to the care partner and eliciting that from the care partner in the visit. And then also another reminder from Barbara about getting the pre-appointment sort of questions written down and maybe coming with those notes or questions in advance of the visit.
Beautiful.
And then Gay Wellman also adds that Alaska is in the process of developing an Alaska-specific dementia road map, and Alzheimer's Resource of Alaska has wonderful programs and services that we've heard about as well. So thank you. Okay, please go on.
Yeah, and so thank you so much for that contribution from the community. When we think about dementia and we think about prevention of delirium, again, we need to know what the baseline is. So we need to detect it in the first place, and then we need to monitor it over time. And these are some of the tools that we use. And I bring them up just to emphasize that there are several, there are many. That is not the focus necessarily of the Project Echo today, but you've either heard about them or will hear more about them. But also to say that when people have delirium, it's not the time to do the MOCA. And I can't tell you how many times we get asked in the hospital to like go see a patient who's delirious and they ask us to perform cognitive testing, and that is actually just not appropriate. And that it's sort of debatable how long you need to wait to sort of do your cognitive testing, but you need to wait some time. And this is all a moving target because we know that like we need to do this testing in part to diagnose dementia when it hasn't been diagnosed before, but when to do it, it needs to be really carefully considered when someone has, for instance, a hospitalization with an infection leading to delirium. So next to our next M we're moving through is mobility, and somebody pointed out earlier how important mobility is. And mobility here is I'm showing you that help program. This is sort of the summary, and mobility comes in every sort of bundle of that you're going to see, like from a hospital perspective in terms of preventing, assessing, and treating delirium. But I think it's also key for us to think about in our primary care teams, right? Because mobility and staying active can prevent injuries, right? Mobility and active can staying active and doing some physical therapy for balance and strength can actually prevent the falls in the first place that lead to the emergency room, that lead to the surgeries, that lead to the hospitalizations that end up so frequently with delirium. And so it's a key piece to what we do in primary care. And I think it's really important to keep that in mind. Okay, so nutrition and hydration. So malnutrition is sort of the last M. Malnutrition is an important marker for so many things, but I'm thinking about this in terms of nutrition and hydration, and how do we take care of our folks in the primary care setting? How do we coach our care partners to try to prevent these problems that, again, dehydration can, right, like just in its basic pathophysiology can lead to decreased brain perfusion, right? And you can see people delirious because of dehydration. And this is, not an exaggeration. We see this all the time. And then we also know that with aging and dementia, you have a decreased thirst response. You may not be able to sit and attend to drinking a full serving. You may have some swallowing difficulties. And another topic for another day is, the thickened liquid recommendation for aspiration prevention, like such a strong delirium risk factor or dehydration risk factor that can lead to delirium and needs to become decided on in a very thoughtful way. And then nutrition, again, I won't be going into a big detail, but like so important, and itself, malnutrition has been correlated with delirium risk. And I think key here is how we can coach our patients or people that live with dementia and their care partners on how to prevent these things. And so I don't think any of these are sort of surprising, but I think, taking, for instance, something like this and putting it into an after visit summary for care partners to be able to review is really important. Keep water close, set reminders, think about how much how much that your care partner or your person living with dementia should be drinking and making those recommendations. You don't have to stay hydrated with water. You can, if somebody, especially, anyway, if they like milkshakes, that's one way to keep them hydrated. And I think it's really important that we think about creative and meaningful ways to do this. Nancy probably has already talked a little bit about the Mayan Diet. So the Mayan Diet stands for the Mediterranean-Intervention for Neurodegenerative Delay. And the idea is that we have some evidence that this actually helps slow the rate of cognitive decline, perhaps preventing dementia in people who don't have it, and perhaps slowing dementia in those who do. And I think we're sort of like waiting on more data, but the whole point here is healthy food is good for the brain. People who don't eat healthy food, and you can see these recommendations. I will also say that the Mayan Diet has some elements that like poultry and fish that are part of the Mayan Diet, but like whole food plant-based diets are also thought to be really nutritious and important for frail older people. And if we can get people eating, especially get people eating things that they would like to eat, we can prevent nutritional deficiencies that also put people at risk for delirium. And so I'm just going to speak to this briefly. We need to be able to coach our care partners about what delirium looks like. And I think that most people think delirium is hyperactive delirium, when people are restless and agitated and moving and cannot control their behavior. But actually, and more commonly, we see hypoactive delirium, right? Where there's decreased activity, decreased speed, slow speaking, people looking listless, withdrawal from things. And we need to make sure that our care partners are looking for that type of delirium as well. And so how do we screen for delirium? The tools, the 4AT and the CAM, of which there's multiple versions, the confusion assessment method, that's probably the most common tool that's used in the hospital. We use something called the CAM 3D, which is just a little more detailed. The 4AT is a good screening tool, but generally as the primary care team, we are looking, the essential elements of delirium are acute onset and fluctuating course. So if somebody is confused and withdrawn and it's not new, it's not likely delirium, right? So it's acute onset, fluctuating course, and inattention. And again, this is hard, especially as dementia progresses, right? Because attention may be something that they struggle with from a dementia perspective as well. But if somebody is typically able to engage and pay attention and have a conversation, and then all of a sudden they're not able to do that, that's really important in terms of trying to identify the delirium. And then, of course, for us as the primary care team, getting that information from a care partner and trying to figure out why. And then disorganized thinking and altered level of consciousness is also part of the picture that we're looking for. And so the CAM was developed by the confusion assessment method by Sharon Inouye, and I'm not totally sure I'm pronouncing her name right, but she's like a amazing, she's sort of devoted her entire life to like researching and addressing and educating people on delirium. And her teams have also created this really cool tool that I did not know about until I started preparing for this talk, which is the family confusion assessment method. So this is specifically for care partners. If you are concerned about delirium, you can administer this tool to try to identify if this is the case, and if this is the case, if there is delirium on top of dementia, why? And so really, really important. And when I asked, again, some of my colleagues on Twitter, one said, we must detect to manage, right? So we must look for the delirium and detect it, right? But also that our caregivers can be trained to do the confusion assessment method and understand the basic common cause of delirium, so they know what to look out for and they can let us know as the primary care teams. And I think this should be part of like a curriculum, so to speak, that you, and there are many good examples of dementia care programs where there's a curriculum where either the primary care team, a specialty care team, or a trained health worker can help care partners understand lots of different aspects about dementia so that they can feel well supported. And one of those aspects would be how to detect delirium. I'm getting to the end and we're at 1:42, good. So the other thing that we are asked for in primary care is we are asked to sort of give our blessing, so to speak, to discuss and to think about whether people should have certain surgeries and mostly to do pre-operative evaluations. And so this is really important. We need to consider for people living with dementia their risks of a certain procedure. And we know that surgery and anesthesia are potent stimuli for development of delirium. We know that surgery itself, even if it's not done in the brain, can trigger neuroinflammation. And so we need to think about those things. We need to make sure we understand, right? If you've diagnosed somebody with dementia 5 years ago, we want an updated cognitive evaluation before they get their surgery, right? Because we want to know where they are on their dementia trajectory so that if they present with delirium, we'll know it's a change, right? We want to be scouring that medication list and we want to be identifying and trying to deprescribe high-risk medications. And then ultimately, with all of those things sort of in mind, if there is a discernment on whether this person living with dementia is going to get their right hip replaced, we're going to think about what matters to the individual. We're going to think about what their individual risks are, and we're going to think about the benefits of the surgery. And then we're going to talk about whether to proceed, and if we proceed, to proceed in the most safe way possible. This is really, really important. And I think often, especially like, for instance, if somebody comes to my primary care clinic for a pre-op, I can't tell you like I always think in this way, but I'm encouraging you to, and I think outlining it here is going to encourage me to do the same. And then just sort of wrapping it up with this, again, coming back to the M of what matters. Mary Tinetti is another leader in geriatrics, and she and her team at Yale and all over the country have sort of developed this other tool, I think, to just maybe basically get at what matters to folks. And I believe you guys have been introduced to this idea, which is you're basically identifying people's health priorities, but also focusing on the burdensome aspects of their care and trying to like specifically address the burdensome aspects of their care. And, you know, when we clinicians consider current or potential interventions, if we can simplify the polypharmacy that the patient so desperately wants us to, if we can maybe have a frank discussion about whether a surgery is appropriate, and we can prevent the thing that may have led to delirium in the first place, I think that's, you know, one of our key roles. And then also to reconcile recommendations from multiple specialists and to come back to sort of what matters to the individual and think about, well, is that specialist recommendation burdensome to you? And should we do it? What are the risks of doing it and what are the risks of not doing it? And I think this is all key in thinking about dementia, delirium prevention. And I just wanted to bring kind of what this might look like in a progress note to you. This is the patient priorities care template, and you can get this from the website. But you know, when I have tried this in my practice, I zoom right in on the burdensome care and the burdensome medications, and I see, well, what can we do and how can we talk about this in a real way? And I think this type of like active management of addressing the burdens of someone's care is, to me, it just goes part and parcel with delirium prevention. I am at my second to last slide here. So this is one of the things I talked about, leveraging our EHR. So this is a health system, Anne Arundel in Maryland. They actually have, for those of you familiar with Epic, they have an age-friendly snapshot. And they have the last time a certain M has been assessed and what the result is. And so if you think about, I think this is so brilliant, because if somebody comes to the hospital and shows up delirious, you can open your age-friendly snapshot and you can see what their MoCA score was from 2 months ago, or see what their depression screen showed, or identified high-risk medications that were being considered, or what their mobility baseline is when they're like strapped to the bed. All of this is so important as we think about age-friendly care across the care continuum. So if I have done my job, we reviewed the age-friendly health systems 5M framework today. We understand now better delirium risk from the primary care perspective. We can use the age-friendly health systems 5M framework to actively prevent delirium in people living with dementia. And we've just touched upon the patient priorities care tool and how you can use it to address complexity of care for the folks you care for. So if you're able to actually get to my slides, and Amber and I can talk about this, these are just links of some of the tools that I mentioned throughout my talk today. And we can just think about, if you're not going to actually get the live slides, we can think about creating this in some other way so that you can read more, especially about the things that were useful to you.
Carrie, thank you. That was so outstanding. So practical and so really deep, you know, around the complexity and really patient-centered, meeting the patient and family where they are. And so I'm going to open it up for questions, but let's see here. There was a question about Teepa Snow, question mark?
Oh, yeah.
Sure.
Yeah. I love Teepa Snow.
Yeah.
I've never heard her live, but first of all, she has a podcast and she also has like a ton of YouTube videos. And so if you're wondering, good resources for care partners, she's a great name. I think she, correct me if I'm wrong, community, but I think she is like an OT that has special training and interest in dementia care and focusing on care partners. I do not know whether she has a special like series or talk on delirium, but I wonder, we could Google it and see.
Thank you. And then let's see here. If caregivers know what to look for, yeah, this is a very important observation by Emily. Do you want to unmute yourself and share that, or do you want me to read that?
Yeah, thanks. I just know that the education for the caregivers is so important, so that if they start to see like a kind of rapid decline in their mentation, they kind of know what the next steps can be to prevent it from getting too much worse.
Thank you. Yeah. And then Gay, do you want to ask your question about families?
Right.
Okay.
I just wanted to see how would one get training to be able to help families with the CAM and some of this other. You mentioned that there was a process for doing that.
Yeah, well, so Nancy and I have explored the dementia care ecosystem and just about maybe launching it sometime somewhere in Providence. And I don't know where that process is, but that is one, if you guys want to read about it, it's called the Dementia Care Ecosystem. And they have a, I can't remember what they call it, Nancy. It's like a community health worker, essentially.
Care navigator.
Care navigator.
Yeah.
That is not a nurse, that is not a social worker, and that is not a doctor or nurse practitioner, that has a curriculum that they review with dementia care partners when the diagnosis comes and say, these are the things you need to learn about, or let's talk about this. And so I don't know. In fact, I'm not sure whether Delirium and specifically the FamCam is part of that. I think this is like novel, to be honest. And I think it's also like makes a lot of sense and it's really important. And so creating programs that can train care partners is there's a lot of effort being put into it, and it's really, really important.
Yeah, we kind of do that. We kind of do that already, but I was specifically interested in this thing about the dementia because that's come up for me a couple different times with different folks where their loved one ends up in the hospital or even prior to that with dementia, and it's just trying to figure out how to help them understand this. This has been very helpful. I also made a comment about the fact that I really appreciate your sharing about the fact that care partners can get really confused when they have different professionals telling them the different things. Yeah. And the idea of who should they go to get that sorted out.
And I'll just add, Carrie, since you mentioned the care ecosystem, that is being piloted in Oregon, actually, in conjunction with UCSF, with Marian Hodges, who's a geriatrician down there. So it is at the moment. Stay tuned.
So Nancy, the Barbara is asking, did I say that anticholinergics can hasten dementia? And the answer is yes. And there have been multiple studies looking at this. And this is about, again, getting back to this idea. It's not for your patient that takes Benadryl once a month for like horrible allergies, which I would advise against anyway. But this is about a high anticholinergic burden, which means higher dose, multiple anticholinergics, higher anticholinergic potency over time. And that has been shown, and I can link article or two in the Zoom chat here that explains that a little bit more, or demonstrates that, I should say.
Thank you. And I would also refer people back to the talk in Kyla's discussion about anticholinergics last week as well. So that there was some resource there, and around deprescribing in particular for anticholinergics as well. Is Kyla? I don't see Kyla today, but I don't believe.
Sorry, she's on vacation.
Okay.
She's not allowed to take vacation.
Any other questions or comments?
So this is Amber. What I'll do on next Monday when I send out the slide deck to everybody, I will actually send the link to the FamCam tool because that was of common interest to a lot of people.
Great. Thank you. Anybody have any other thoughts or questions or things they want to share? Did that case speak to you, or? I see Carrie's just put in the chat a reference about this association with anticholinergic burden.
I will mention,
Just to
I think
mention
this
this.
probably is going to be of interest to you all. Pat ended up back in the hospital a couple weeks later. Actually, it was about a month. She got a month home with Leah, but she in fact fell and broke her hip. And we've been dealing with hospital delirium, you know, and there's an overlap, right, with behavioral symptoms related to dementia. But it's helped us dig deep into some really difficult discussions about, okay, well, what mattered to you was that you went home and were with Leah. And if we act on what matters to people, that doesn't mean we take risk away per se, but we live with that risk, and we hold that risk while we also hold the fact that, like, if she chose, she probably would have chosen to go home, even if it meant having this bad outcome. And so I think that's really important to understand that, like, these decisions that we make, or when we focus on what matters, like, there's often a lot of gray, there's a lot of uncertainty, and that's okay. Like, that's part of what we do, is we help walk the journey with folks through that uncertainty, and sometimes through the bad outcomes as they come.
Not sure there would be much time to address a topic as difficult as the one I'm going to bring up, but during the pandemic, the visitation guidelines and the impact that's had on people with dementia, and especially on kind of their delirium risk and palliating the delirium, has been, has been astronomically impactful for the care of people with dementia. I know from the hospital perspective, different states have enacted laws that have set some guardrails around what hospitals would do, but Alaska didn't have any state laws that defined that. I don't know if you're finding that people are talking about best practice, excuse my dog, but best practices for, like, what we've learned and what we need to do going forward to provide the best care possible for people while we keep our caregivers as safe as possible as they care for them.
It is a huge question, and thank you for bringing it up, because it's so core to what we've dealt with. And so I really honestly haven't been part of and I would like to be more part of sort of advocacy related to this, because I am certain that care partners are essential parts of a care team in the hospital, period. Right. And we just need to figure out, right. And then also, I've been caring for people with COVID for 2 years now with PPE and have not gotten sick, right? I mean, knock on wood. And even if I did, maybe if I did, that's actually not important. We know, let's just say we know how to keep people safe, and how to both keep them safe and keep other people safe. And that's with appropriate PPE. And so if we really want to make this work, if COVID is not going away and we see other times, because we are opening up our, and I think many sites are sort of opening up, flexing a little bit on visitors right now. But if we need to face this in the future, I think your question is really important, is how do we put some guardrails? How do we have best practices? How do we actually just make sure people understand it's not okay to, and these are the outcomes when we don't allow care partners in the hospital. Yeah.
Yeah.
Thank you, Ursula, for bringing that up, because that's something we've been facing here in Alaska. I know I've had several clients, families that were frantic, called me frantically upset because they couldn't, their person had been taken away. And then, well, the ironic thing is, no, you can't come in, no, you can't come in. And then a day later, they're saying, come in, help us with this. And it's like, told you, it's like doink. I think it is getting better, but it's been a hard pull. How do we as professionals advocate for that? We're not hospital people, but
right. And for what we do for this next year or two going forward, right? Because it is different for all the reasons Carrie described, with our knowledge of PPE and how to test for and minimize risk of COVID. And then what do we learn the next time when we close things down, and what's considered essential? Because losing the care partner for the bedside of someone with dementia has had a huge impact on the care of their ability to respond to the care in the hospital optimally.
It can't be just one person. There needs to be more. You can't say, well, okay, we'll let you in, but we can't let your husband in, or we can't let your daughter in, or anybody else. So you get to do this for 24/7 again. And that doesn't work.
Right. So these are so important. And we are now at 2. Carrie, is there one more slide about next?
Nope, that's it.
Okay. Okay. Thank you again. Oh, there we go. Okay. Thank you again. And we will see everyone in 2 weeks this time. We are back on track every 2 weeks.
And I would just invite folks, if there are some things you wanted to know or learn more about, or want to discuss, this is all stuff that I am very passionate about and interested in collaborating or discussing. And so please reach out to me. Amber has my contact, but it's just my first name dot last name, Carrie.Rubenstein@swedish.org.
And Carrie, maybe stay on for a moment as we're
happy to.
Okay, great. With the hub. Thank you all. See you in 2 weeks.